So, we are moving to our initial concluding stage. In our second concluding phase, we're going to talk to you. But first of all, we would like to draw some conclusions from our project phase. INSEA is a project which was developed early on, and Mrs. Keidel has actually said it early on during our discussion round. The concept was developed at BAMA, and BAMA was approached whether they would like to carry out this project, and later on the Hannover, the medical university, joined the project. Mrs. Keidel was the head of the self-help agency in Bavaria, their headquarters in Würzburg, and they are providing help, or they're providing networking help for 34 contact points in Bavaria. So Mrs. Gönül Temucin and Mrs. Keidel are going to present the next presentation. Mrs. Temucin has been working in this project since 2017 at the Medical University of Hannover, and she's an occupational therapist, and she also studied public health. So both of them are trying to draw some conclusions based on what we heard today several times. Mrs. Merlin has summed it up quite well. So what happened to the project during COVID? I think many of us did not anticipate that, but we managed to succeed. And I'm looking forward to their presentation. The floor is yours. Go for it. Thank you, Mr. Kösters. So today we heard a lot about INSEA already, and now I would like to tell you about our experience, successes, and our obstacles. So summing up, INSEA stands for the Initiative for Self-Management and an Active Life. The implementation is facilitated by the Robert Bosch Foundation and the BAMA Health Insurance. And we are in the third stage of our project. It's going to be completed in 2023. We managed to develop a cross-regional network. We started in Hannover by setting up a national coordination body. And we also established a steering group. We added site partners, SeKo Bayern, Gesunde Kinzigtal, and since last year we also had the working groups of Hesse, Brandenburg, as well as North Rhine-Palatinate, just like Port Velingsing. I'm going to keep it short and sweet because we already talked about many of these points. The course lasts 6 weeks, once a week for 2.5 hours. They hold meetings. The workshop leaders are affected by a disease themselves, and they are trained by a Train the Trainer workshop specifically for this course. We have manuals in every course, so during these 6 weeks, the participants can follow up on the contents of their workshop by looking it up in their manual. So it's about health, nutrition, relaxation, setting up plans for action, but we also have medical adherence. What are the aims of medications? So it's about taking on responsibility of your own medication management as well. All of this is part of the contents. We started with in-person workshops that were held with just very limited resources. We had to switch to online classes very quickly. And Mrs. Seidel has just said it. We started with a so-called Session 0, which is a pre-course in order to talk about the technical specific or specific points of Zoom, for instance, and also giving participants the opportunity to ask questions before the classes start. We try to make sure to clarify as many things as possible before the classes start, so that this does not interfere with the actual contents of our classes. Last year we added telephone classes. Before the telephone class starts, our participants get the material sent to them by mail, as well as the tests that were presented by Mrs. Lorik. So it's just like a regular telephone conference, and we received a lot of feedback from our participants. They really want to maintain this format because they enjoyed the telephone calls so much. We evaluate these courses before the course, 6 weeks after the course is done, and 6 months after the course has ended as well. Our workshop leaders help us with our evaluation, especially with regard to in-person classes. They distribute the surveys and they explain to our participants how important that is for our project. Of course, they are anonymous, and our telephone classes are evaluated by paper surveys as well. Our online classes are evaluated via an online survey platform. The data we generate are about demographics, standardized ratings that we have, and tools, as well as other resources. So here we present the courses we held between 2015 and 2022. We had 2,582 people that participated, and we broke it down to the different formats. In-person classes were attended by 2,265. Online classes were attended by 298, and we had 11 participants in 3 telephone classes. Our dropout rate was 13%. This is due to the fact that some of our participants got COVID, had a severe progression in their chronic condition, or they had to drop out because of rehabilitation interventions that they had to do. Who are our participants? Very important for us to know. As you can see, based on the numbers, we have not as many men as in the United States. 3/4 of our participants are female. Can you see the slide? Something that's striking is that 54% of our participants in person are retired. Oh, pardon me. And online, 26% are retired. And we can see a difference between the online as well as the offline participants and also the telephone participants. In our telephone classes, 87% of our participants suffer from one to several chronic conditions. In our self-help group, we have participants that attended mainly online courses, and that is due to the recruitment strategy that was applied. These are quite specific data. Different course formats address different target groups. Let's take a look at the distribution of the conditions, or as you can see, many women say that they have physical disease, and we saw that more people suffered from a mental disease in online classes. Men actually suffered from cardiovascular diseases more than others. Let's take a look at the impact of our in-person or face-to-face classes. So there are differences to the United States. Online as well as in our telephone classes, we can see there's an increase in self-management skills and self-efficacy. So this is actually across all of the different formats. This applies to face-to-face, online, as well as telephone classes. We want to present some impressions of our participants. Mrs. Carlotti has already described it quite well. These are some quotes of our participants. This course has an impact on many different levels. Here is a quote: "Up to this class, I did not know what I'm supposed to do. And now, after having attended this class, I know what I can do. It took a little while, but then I made an appointment." This is what we heard very often. The composition of the group was very good because not everyone is suffering from the same disease. This way we have different input. So the cross-disease concept works quite well. The action plans are working well. Adhering to my action plan helps me to improve my diet as well as including more movement into my life. This is actually feedback from a Turkish-German class that we held in a Turkish mosque. And here you can see a picture of that, and we're sitting on the floor. As you do in a Turkish mosque, you sit on the floor. In terms of networking, I would like to point out that Hannover is taking its own path. We have a different kind of structure than others. We tried to make this part of the communities. We tried to get to know the people's lives. We talked to community managers. We talked to savings banks. We talked to educational institutions. And we talked to different institutions, organizations, in order to plan courses with them and host them with them. There's something special about the Bavarian model, and my colleague, Mrs. Keidel, is going to touch upon that. I'm very pleased that we get to sit here, that we have this physical symposium. Of course, we weren't sure whether that was going to work. We were here before. Thank you very much again to the Robert Bosch Foundation that we get to use their beautiful headquarters. Pardon me, I lost track. So these are the goals. I don't think I have to read them out again. In Bavaria, it was about setting up self-help groups for self-management and to find the link to self-help. So recruiting new people via INSEA, we wanted to integrate them into our self-help in our healthcare system. We succeeded. Before COVID, we had greater success than after COVID, but I'm going to talk about this in detail in a minute. We set ourselves apart in Bavaria. We started a little earlier. We actually started in the middle of 2014. INSEA was supposed to be a bridge to self-help in Bavaria. So we offered a 7th night. So we had 6 nights of the regular class, and during the 7th night, we facilitated networking, and we tried to connect self-help groups that were outlined in the classes. So during the course of the years, this so-called 7th night sort of became a party, a self-help party. People brought dishes, they did some networking, they mingled, and this way we had great follow-up groups and follow-up coffees that were launched. Right now we work on 6 locations: Augsburg, Bamberg, Kempten, and in the rural area of Main-Spessartkeit, Munich and Amberg just joined the project recently. Our workshop leaders were usually made of 2 people, 1 person of the local contact point, and the second person was someone who has been working in self-help for many years already. We then had these two people leading these workshops, and we did some testing. So the person from the contact point were actually affected by a chronic disease themselves, either because they were suffering or because they were a family member. And then we were hit by COVID, which represented a great challenge for all of us. It was very difficult for us to switch our format, and together with our counterparts from Hannover, we managed to make the switch. And we added this so-called seventh night, which led to self-help for us. And we did not want to add the so-called session zero. So we used the session zero to introduce the points of contact for the self-help group. What we enjoyed before COVID is that we had INSEA self-help group that were formed and that were pursuing their action plans together. In Augsburg, they set up an INSEA coffee shop, and once a month they set up a program that was prepared by the workshop trainers, and that sort of led to some sense of community. So COVID. Unfortunately, some of our workshop trainers were not able to deal with the new format. But despite that, we managed to combine different formats of Bavaria. Bavaria is quite a big federated state, and we had 6 different locations that usually worked isolated from the other ones. But now we managed to combine different workshop trainers, workshop signs, which was quite a lucky strike for us. Otherwise, we would have not been able to transition to the online format. So what was the advantage? Well, it was more easily accessible for those people with a handicap. So we had quite a wild mix of people in our groups. And one upside was that other self-help regions joined our Bavarian classes. And judging by the feedback that we got, people enjoyed this format a lot. Not just this cross-indication mixture, but also those regional mixture contributed to a successful format. One downside was that the follow-up INSEA activities decreased. Due to COVID, they were not able to follow up on these courses. Unfortunately, this led to some people stopping offering more INSEA follow-up activities. And on the 7th night, we actually integrated our session zero. We also offered telephone classes, but they were not accepted by our participants. We held one telephone class, which was pretty successful. And tomorrow, the workshop trainer is going to tell us more about this in detail. I think this one went quite well, and I think we should give this one a chance. And let's hope that this is not going to happen, but if we have another outbreak of COVID in the fall, I believe the telephone class might be a good replacement for those who cannot attend online classes, or can be a good substitute. So we had to stick to the COVID regulations, keeping our distances. We needed big rooms to keep the distancing rules. But we managed to carry out some in-person, face-to-face classes, and people were very happy about that. And we compiled 3 core statements. So number 1, INSEA provides for people who suffer from chronic diseases. This might be a very helpful grassroots program. And something that I kept hearing was that the action plan is the core element of this plan. And this, I think I remember you saying to actually using public transportation. And this is also what I hear in my INSEA feedback talks. Some people rate themselves with 7 or 8, so it seems to be quite a good, powerful tool in order to have a more playful manner in their own management. INSEA managed to switch swiftly to online and telephone courses during COVID. I think this is due to the great cooperation with you in Hannover and us. So in the fall, we were able to manage and offer these online courses. They were quite accessible, and we had a combination of different workshop trainers from different regions. So I believe we could still work on that because it was quite positive for us as an experience. The INSEA program could be more cost efficient than patient training because we can offer it across different diseases and we have positive impacts. And this could be hosted by volunteers. Thank you very much for your attention.